it's a good question. Really, both of them are examining the role of a novel therapy under study called UGN-102. This is a formulation of mitomycin instilled in a proprietary gel that allows for additional contact time of mitomycin to the lining of the urinary system in bladder cancer. And so really both studies are designed to look at the efficacy and safety as well as durability of that agent in a condition called intermediate risk, low-grade, non-muscle invasive bladder cancer. So in ATLAS, this is really the entire population of patients who fit this definition. This includes patients with tumors greater than 3 centimeters, patients who have multifocal or multiple tumors when we look inside the bladder, and patients who have recurrent bladder tumors that appear within multiple times within a year. That's ATLAS. ENVISION is a little bit different. It looks at specifically patients that have been previously diagnosed with low-grade bladder cancer and then have recurred. So it's a little bit of a subsegment of that first population, but really comprises still a vast majority of our low-grade intermediate risk prostate cancer patients. So a little bit of a different study population, but again, all of these are high risk of recurrence, low-grade bladder cancer patients, which comprises basically, around half of all the patients that we see in general who take care for bladder cancer. ATLAS was a randomized double-arm study. It randomized the gel, which is instilled via a urinary catheter. This can be done in the office under local anesthesia, the way that we as urologists give therapies all the time inside the bladder. It's given once a week for 6 weeks, and that's sort of the study arm of ATLAS. It's the same installation schedule that you'll see in ENVISION. ENVISION, however, is a single-arm study. So all patients in ENVISION only received intravesical therapy with UGN-102, the study drug. Whereas in ATLAS, half the patients received installation with the study drug, and the other half were randomized to the standard of care, which is transurethral resection of bladder tumor, or TURBT. This is what we've been doing to eradicate bladder cancer in the bladder for decades and decades. So again, ATLAS, a double-arm study, that's the one that was published in the Journal of Urology recently. ENVISION is a newer study where we have just publicly released data regarding the 3-month outcomes, but the durability of response for ENVISION is not yet available. So again, mitomycin is something we've used a lot of. We've used this for decades in urology. It typically has been historically used in the adjuvant setting, meaning we do a complete resection and then we gave some sort of intravesical chemotherapy, historically mitomycin, into the bladder after therapy. So again, it's an agent and a drug that we have a lot of experience as urologists placing in the bladder. And so there's some data understanding how well it works. These are obviously 2 phase 3 studies. So there have been phase 2 studies looking at this drug in humans. And in general, what we find, and it's very similar across these 2 phase 3 studies in both groups, is that the treatment emergent adverse events, the percentage of serious adverse events is typically in the single digits. So we look at the published study, the ATLAS study, that rate was about 9% in the study group, and then about 5% in the TURBT group, the resection group. So again, less than 10% in both arms. And actually, study investigators deemed none of these treatment emergent adverse events as being study treatment related. And so in the drug group. So the types of things we see are the types of things that we see when we catheterize someone several times in the office over the course of a month and a half, are things like urinary frequency, urinary urgency, getting up at night a bit more often. That's sort of what we call irritative bladder symptoms that sort of are transient typically and get better. These are usually self-modulated by patients. They're reported, but then they're not really treated in any particular way in the majority of patients. So again, safety profiles are really consistent with use of the study drug in prior studies, as well as the use of mitomycin historically. And again, you're looking at single-digit, significant adverse events, most of which were not deemed to be related to the study drug itself. Again, remember, these patients are receiving a catheterization 6 times over 6 weeks, right? So some of the urinary irritation symptoms, they may be coming from the catheter as well. So it's hard to tease that out, but it's low overall. And significant serious adverse events are really uncommon in any of the study arms of either study. That's the hallmark question. There's really 2 things that we look at as urologists when we talk about bladder cancer, especially low-risk recurrent bladder cancer or intermediate-risk bladder cancer, is how well do we do with the first treatment? So we treat you, how are we doing when we take a look back inside the bladder? So that's a 3-month complete response rate. On ATLAS, those 2 numbers were almost identical. Is about 65% of patients who received the study drug had a complete response at 3 months, and just slightly lower, 64% or so of patients who had TURBT, very similar. So I would say the 2 numbers for complete response rates are very similar between the two arms. And again, remember, we're picking a patient population where the disease is recurrent. We've kind of picked a population where we know these tumors come back. That's kind of how intermediate risk bladder cancer behaves. And so we're seeing sort of, similar numbers or equivalency at the 3-month outcome. I think where the study drug seems to have an advantage potentially is in the durability of response. And so when you follow these patients out, as I mentioned, we've sort of pre-selected for a highly recurrent patient population. We follow these patients out 6 months, 9 months, 12 months, even out to 15 months. We're seeing that overall, there's a reduction in the risk of recurrence, progression, or death in patients who receive the study drug versus patients who receive bladder tumor, a resection of a bladder tumor, a TURBT. And I think in some ways it makes sense that that's the case. When we do a TURBT, we're actually going into the bladder, we're visually identifying a tumor to the best of our ability, and we're shaving away that tumor that we can see. If we don't see another tumor elsewhere, we don't go and resect sort of piecemeal or randomly to determine where things may or may not be. So we know from the use of some advanced technologies in bladder cancer, cystoscopically, namely narrowband imaging and blue light cystoscopy. These are two sort of newer therapies that allow us to see a bit better when we do a cystoscopy compared to what we've historically done called white light cystoscopy. Those technologies have demonstrated that we are actually able to better see small tumors that otherwise would be missed on traditional white light cystoscopy. The reality, though, is that these newer technologies, blue light cystoscopy and narrowband imaging, are not universally available. They're expensive, and not all urologists use them. So the majority of urologists are still using traditional white light cystoscopy like we've used in the office and the ORs for decades and decades. So we kind of already knew that white light cystoscopy was not perfect, meaning that if we had a better technology, we'd see really small tumors. We just can't see them yet. And the good news is, while that's not necessarily overwhelmingly dangerous to a patient, because low-grade tumors take a long time to invade, it does become a reason why we see recurrence. They might have been there on that cystoscopy, we missed them, but took 3 or 6 months to eventually see them, right? And so I've heard a urologist describe this as sort of a whack-a-mole strategy, right? TURBT is when you see something stick its head up far enough, you kind of kill it there, wait for the next one to stick its head up and kill it there. The study drug is very different, right? We don't inject it into the tumor. It's instilled into the bladder and is given throughout the entirety of the bladders, right? So it's coating the entire lining of the bladder. So there's no particular area where it's aimed except the entire lining of the bladder. And so it makes sense that if it can treat tumors that are visible and make about 2/3 of those tumors go away at 3 months, it's also on top of and treating potentially a really microscopic or small tumor you can't see yet and providing potentially the same benefit. And where you're going to see that is not so much at 3 months, because those tumors aren't really visible at 3 months yet, but you're going to see when you follow patients out. And that's where overall there was a 55% reduction in the recurrence, progression, or death rates in the study arm compared to the patients who received TURBT alone. And so I think that's really where there's a lot of excitement about these novel therapies, is even if they're equivalent up front, it's really exciting to see that they may have a durable response out later, because every time we can avoid another tumor from recurring, that's another time we don't take a patient to the operating room, another time we don't give them anesthesia, another time we don't pause their blood thinners. Remember, these are older patients. I mean, the average age for bladder cancer is about 75. Most of these patients have existing cardiopulmonary disease. The number one risk factor is smoking, right? So these are kind of older, sicker patients. A lot of them are on blood thinners. We have to leave catheters in afterwards, sometimes after resection. So, anytime we can sort of take that off the table and avoid an operation in the future, I think is inherently advantageous for patients. And so, I think that anytime we do a surgical randomized trial, these are really hard to accrue to. And I applaud the other study investigators, because patients have to be randomized to surgery or a treatment. And that's really hard to do. But I think both patients and investigators saw the rationale for this kind of study to try to find another non-operative intervention tool in our armamentarium, and seeing the data as they are with, really equivalent 3-month complete response rates, and then seeing a durability of response when we talk about UGN-102, the study drug with or without a resection compared to a resection alone. We're really seeing the durability of this treatment sort of long lasting into, 9, 12, and even 15 months.